Hello friends. At the outset, I am really thankful to the organizers for providing me this opportunity to share my thoughts with all of you regarding the pharmacological treatment of insomnia. So in next 30-40 minutes or so, we'll be discuss about what is the problem statement and why we are discussing about the treatment of the insomnia. Then we look at the developmental history of different kinds of the molecules. We will discuss about the issues which are related to the use of the hypnotics for the management of chronic insomnia, as well as and when I talk about the hypnotics, it will include both the benzodiazepines and the Z drugs. Then we will look at the critical assessment of the issues. Then we will try to find out, do we have any safer alternative for the management of chronic insomnia? And based on the discussion so far, we will try to look what is the best treatment alternative for the management of chronic insomnia, followed by the summary of the presentation. So if we talk about the insomnia, so one of our study has found that nearly 10% of the adults in India, they report the insomnia. Of course, we did not look at the lifetime prevalence, so this was the point prevalence. And what we expect that when the point prevalence is around 10%, the lifetime prevalence would be much more. Now, insomnia we consider it's a mild illness which is self-limiting, self-remitting, and many a time we consider insomnia as a symptom of another psychiatric disorder, but this is actually not true. And our recent classification systems in psychiatry as well as sleep medicine, that is the DSM-5 and the ICSD-3, they clearly mention that when the symptoms of the insomnia, they are burdensome, they are causing some kind of toll on the person's life, then the person should receive an additional diagnosis of insomnia even in presence of other medical or psychiatric disorders. So Ellen et al. Tried to understand what is the economic burden of the insomnia. So they found that if we discuss in terms of the US dollars, the insomnia costs nearly 100 billion per annum. Now the costs incurred towards the insomnia, they come from two different sources. One is the direct costs, which are the costs incurred towards the treatment of insomnia, and second are the indirect costs. For example, a person with insomnia is not as productive as a healthy person is. Many of the patients who are suffering from severe insomnia, they are not able to function well and they are frequently absent their work. Then the patients who are suffering from insomnia, and if they are say commercial drivers or they are working in some industry, then they are more likely to meet accidents. Then untreated insomnia also increases the risk of other psychiatric and medical disorders, for example depression, anxiety, substance use disorders, hypertension, CAD, to name a few. Then there are some unmeasurable costs, for example the costs incurred by the poor quality of life that a person with insomnia suffers, and the social dysfunction caused by the insomnia among the sufferers. So these are the costs which are unmeasurable, but they are actually high, and lot of literature is available regarding that. If we look at the regulation of the sleep and wake, so basically in the brain we have two different kind of nuclei or the systems. So first is the reticular activating system, which is present in the brainstem, and it is composed of the noradrenergic, serotonergic, dopaminergic and cholinergic nuclei. And all these nuclei, they project to the cerebral cortex and they try to keep us awake and alert. At the same time, there is another group of nuclei in the ventrolateral preoptic area, which is a part of the hypothalamus, and this is actually the sleep promoting area. So normally when we are awake, what happens that the ARAS, which is present in the brain stem, it inhibits the activity of the VLPO area. And there is a third group of neuron in the posterolateral hypothalamus, which is known as orexin or hypocretin. Now these neurons, they actually give the positive feedback to the reticular activating system, so we stay awake and alert. In the evening or the night when we go to sleep, what happens? The activity of the VLPO increases and it sends inhibitory signals to the all the nuclei of the reticular activating system, as well as also sends the inhibitory signals to the orexinergic signals to orthogenic nuclei. So what happens? The activities which were promoting the wakefulness and the alertness, they are inhibited and we fall asleep. Now, when a person with insomnia comes to us, so normally what they have, that they have the either the reduced activity of the VLP or heightened activity of the ascending reticular activating system, which promotes the wakefulness and the alertness. So we try to treat the patient, and when we try to treat the patient, then we consider certain goals with the management of the insomnia or any other medical disorder. So what are the goals of the therapy? We want symptoms to be resolved. Whatever medication we are giving, if the illness is chronic, then we want that the medication or the therapy, whether the pharmacological or non-pharmacological, should have sustained effect. The adverse effects should be minimal and there should be no life-threatening adverse effect, and the safety should be established even when the medication or the therapy is used in the long term. And lastly, most importantly, whatever therapy we are prescribing should be affordable. So with this background, I just shift to the different uh, medications which are available for the management of insomnia. So if we look at the different medications, so we had the barbiturates, which were first developed in 1903. They were discontinued because they have a number of adverse side effects. Then in 1960, the benzodiazepines were introduced, but again they were also found to be habit forming. So we looked for another molecule, the Z drugs, and since 1990 we have the zopiclone, azopiclone, zolpidem, zolpidem available. And again with these drugs, we in a number of patients we did not achieve the goals of the therapy, so we looked forward towards the other target, that is the orexin receptors. As we have already discussed, that if we block the orexin receptors, that will produce the sleepiness. So dual orexin receptor antagonists like suvorexant and lemborexant, they were developed. Now, if we look at the different guidelines for the management of insomnia, so recently two guidelines were published in 2017. One is by the American College of Physicians and second is by the European Sleep Society. So in both these guidelines, the CBTI was considered the first line of the therapy, followed by the use of the pharmacological agents like benzodiazepines, Z drugs or the DORAs, and some other medications like antihistaminics. They were also mentioned. But all the pharmacotherapeutical treatment of insomnia was given the second line, considering their adverse effect. But the issue is CBTI as safe as we discuss? Now, when we look at the CBTI, it has its own issues. Every patient of the insomnia is not the right candidate for the CBTI. Of course, you will appreciate that CBTI is also a kind of psychotherapy, and every psychotherapy has its own candidature. So we need to look at the candidature for whether the patient is fit for the CBTI or not. Now there are certain other issues regarding the delivery of the CBTI, because the trained psychotherapists or the physicians who are trained in CBTI, they are scarcely available. Now, these European guidelines clearly mention that 90% of the trained CBTI therapists, they are available in US, and rest of the world it has only 10% of the trained CBTI therapists. So you can just imagine the number of the therapists which are available in India compared to the number of the patients who are suffering from insomnia. So of course we need to rely on the medication to a large extent. Now, when we compare the CBTI with the hypnotic therapy, CBTI is definitely costlier because the therapists are few. Efficacy in the short term is poor, so it is not good for the acute insomnia, but yes, it is good or similar to the hypnotic medications in the long term. Accessibility, as we have already discussed, it is mentioned. Adherence is another major issue with the CBTI, but because it's just another psychotherapeutic technique which demands the change in the cognition, that means the thought process, as well as the behavior of the patient. And the quality of the evidence is actually overestimated for the CBTI. For example, most of the meta-analysis, they do not consider the retention rate, they do not and like any other psychotherapeutic technique, the sham therapies for the CBTI is also not available. If we look at the recent guidelines for the pharmacotherapeutic management of insomnia, which were published in the Journal of Clinical Sleep Medicine, they clearly mention that certain molecules like suvorexant, which is a dual orexin receptor antagonist, azopiclone, zaleplon, zolpidem, which are the Z drugs, their benefits, they outweigh the harm. So the issue is when their benefits are outweighing the harm, and same is true with the certain benzodiazepines like temazepam. So they can be used for the treatment of the insomnia. Certain other medications like doxepin, they can be used. Remeltion can also be used. Tiagabine can be used, but for the other medications like trazodone, which is very commonly given for the management of insomnia, the harms, they outweigh the benefit. So this should not be used. So this guideline clearly mentions that if we talk about the pharmacological management of insomnia, we have to rely on either the benzodiazepine or the Z drugs or the dual orexin receptor antagonist. Now we discuss what are the different issues that have been described in the literature with the use of the hypnotics and the Z drugs. So first and foremost issue which has been described in number of papers regarding the say to which shows that their use should be avoided in the patients with the insomnia being a chronic problem, is the liability to get addicted. Now, when we talk about the addiction to the benzodiazepines and the Z drugs, three terms they appear in literature. So they talk about the abuse, where the medication is used intermittently or at or regularly without any medical indication, but in large doses. Misuse, where the person is using the medication in therapeutic doses regularly but for the medical indication. For example, we all know that the patients of insomnia, they keep on taking the small doses of the benzodiazepines, the alprazolam, lorazepam, diazepam, clonazepam for a very long time. And lastly, the physical dependence, where the dose is taken in the therapeutic doses, but when the person discontinues the medication, he develops the withdrawal syndrome. Issue is, when we look at closely to the symptoms of the withdrawal syndrome, they closely match that of the initial illness for which the medication was taken. For example, withdrawal syndrome mentions that the people, they develop anxiety, they develop sleeplessness. So these are the issues that we need to consider when we are looking at the literature. Now, when we talk about the literature regarding the discontinuation of the sedative and hypnotics for the insomnia patient, we come across two major terms: rebound insomnia and the withdrawal insomnia. Now, these two terms are not synonymous. Uh, the rebound insomnia means that at the baselines, the patient's severity of insomnia was lesser, but as the patient discontinues the medication, the severity of the insomnia it is much greater than the baseline. And in the withdrawal insomnia, the severe symptoms just reappear and in the same intensity, the same severity. So these two terms should be used cautiously and should be whenever you are reading any literature in the medical related to the sedative hypnotic, especially their use in chronic insomnia, that how did the authors define the rebound and the withdrawal insomnia should be clearly observed. If we talk about the rebound and the withdrawal insomnia with the use of the hypnotic and sedative medications, the data is mixed and it clearly depends upon the half-life of the hypnotics. The hypnotics which have the short half-life, they have greater chances to develop withdrawal insomnia compared to the long-acting benzodiazepines and the Z drugs. Certain other issues which have been discussed with the use of the hypnotics are the motor vehicle accident. So, experimental studies have suggested that the hypnotics and the sedatives they increase the risk of the accident, which has been examined using the standard deviation of lateral position. So, during the SDLP, patient has been asked to sit on a simulator. Now they are given the medication and they need to now drive on parallel to a given line. If they are deviating from that line or if you are seeing some kind of swaying, so that shows that the deviation is there is a deviation and that is a marker of the accident proneness after the use of the medication. Similarly, epidemiological studies they have also suggested that the people who are using the benzodiazepines they have greater odds to meet the vehicular accidents. If we talk about the falls and the fractures, experimental studies again we cannot produce the fall and the fracture experimentally. So the studies they have shown that the sedative and hypnotics they impair the cognition as well as the balance. So both of these factors they can lead to fall as well as fracture. But the epidemiological data clearly suggests that the sedative and the hypnotics they have higher odds for the fall and the fracture. Now, this is what the literature says, but what is actually written in between the lines in the literature that we have to understand so that we are say having a clear concept regarding the use of the sedatives and the hypnotics in our practice. So, when we talk about the dependence, there is no data how many patients on the medical prescription of benzodiazepine try to obtain it through the illegal means. Again, when we talk about the dependence actually does not mean only the physical tolerance. It also means that there should be craving, there should be a constant need to procure the substance, there has to be a major social and occupational or the personal dysfunction. So these and then certain withdrawal syndromes or symptoms which were not present when the medication was started. So these data were never analyzed when any of the study was done regarding the benzodiazepine or the Z drug dependence. Then we do not know whether the people who are consuming other substance of addiction whether they have greater chances and how many of them they become dependent on the benzodiazepines. So again the literature is still inconclusive. Of course there is some literature but it is inconclusive to say be a scientific fact. Now, there are two different kinds of benzodiazepines. So, first we talk about the high dose benzodiazepine dependence. Unfortunately, the data for the high dose benzodiazepine dependence was obtained from the patients who were suffering from any other chronic psychiatric disorders, and they were actually given the medications for months. So I mean, having the another psychiatric disorder, and when they were forced to take some medication, so when the medication was discontinued, whether this was the symptom of the original illness or it is whatever symptoms they developed, it is because of the sedative and hypnotic dependence, it is difficult to ascertain. Then most of the studies which have been done, they were small, they had a small sample size. Data is again based on the case reports and certain case series, and major issue is that there is no data available that how many of these patients they use the benzodiazepines and the Z drugs for the recreational purpose, and how many of them they escalate the dose by themselves. But our clinical experience clearly suggests that most of the patients who are suffering from either insomnia or anxiety, they do not escalate the dose even after the long-term use. So once the high-dose benzodiazepine dependence could not be established, then we came to the concept of the normal dose benzodiazepine dependence or the benzodiazepine dependence in the therapeutic doses. So this was proposed as a disorder when the person is using the benzodiazepines for a very long time. For example, a patient having the anxiety or the insomnia is using the benzodiazepine or the Z drug for say months or years together. Now, when these medications were discontinued, an attempt was made. So there was minor withdrawal. Minor withdrawal means the patient they developed the symptoms of the anxiety. Now, another issue is when we talk about the normal dose benzodiazepine dependence, the tolerance was not considered as a prerequisite for the physical dependence. Only the minor withdrawal symptoms, whether it was insomnia or the anxiety, was considered as a sign of the physical dependence. So again, we all know that anxiety as well as the insomnia, in some patients they may run a chronic course. These patients may require long-term therapy, similar to the patients who are suffering from hypertension or diabetes mellitus. So whenever you don't give them any medication, their BP shoots up or the blood sugar rises. Same thing happens in the patients who are suffering from anxiety and the insomnia. So whether this is just the withdrawal of the original problem or it is actually the sign of the withdrawal and the physical dependence is difficult to ascertain. Then normal dose benzodiazepine dependence were never tested in normal volunteers. And as for the high dose benzodiazepine dependence, other parameters of the dependence were overlooked. Now, two recent papers they talk about the use of the sedative and hypnotics in the general population. So they found that only 1% of the general population they are consuming the hypnotics and sedatives for the for the probably recreational purpose but non-medical use. And who are the people who were using it for the against the medical prescription? People who were suffering from anxiety, insomnia, and who were using alcohol in the moderate doses. So again, we say based on these three risk factors, we can come to the conclusion that the people who are suffering from these disorders, they definitely gets benefited with the use of sedative and the hypnotics. And if these are not prescribed by the physicians and the psychiatrists to them to relieve their symptoms, of course they would try to procure it, and that will be considered as a non-medical use. Another systematic review looked at the long-term use of the hypnotics and sedatives. Long-term use was defined as the use beyond 6 months. So it was found that 3% of the general population they were having the long-term use of the sedative and hypnotics, but most of them they were using the sedative and hypnotics in the stable doses and the low doses, that means the therapeutic doses. And the risk factors were the elderly population. Again, say if we talk about the elderly population, we all know that elderly, they do suffer from insomnia, they do suffer from number of other medical disorders, which increases the risk further for the insomnia as well as the anxiety disorder. So it is understandable that why they were using these medications in the long run. Now, when we talk about the motor vehicle accidents with the use of the sedative and hypnotics, so whatever the studies we have discussed earlier, they had certain issues. For example, it was not mentioned in the studies whether the proneness to the accident was caused by the insomnia, because insomnia also impairs the cognition, or it was because of the medication. Then the difference between the drug use as well as the occurrence of the accident was not recorded in the epidemiological studies, and other confounders which can lead to the accident, for example, condition of the road, the condition of the weather, or any other such conditions, they were not considered while concluding the results of the study. Coming to the falls and the fractures, of course, there are certain indications which can itself be a confounder. For example, person who are suffering from another medical disorder are more likely to suffer insomnia as well as um, say cognitive impairment. And so this cognitive impairment and the imbalance, whether it was caused by the other medical disorder, by the medications which were prescribed for the treatment of other medical disorder. For example, say let's take an example of the hypertension. People with hypertension are often given the ACE inhibitors, and ACE inhibitors are likely to produce orthostatic hypotension. Same is the case with the some alpha blockers which are given for the management of systemic hypertension. So they can also cause imbalance that can lead to the fractures and the fall. So this has not been ascertained whether the patients, they were taking any other medication, or they were having the medical illness which could act as a confounder. Now, there is some preliminary data from the recent studies which mentions that elderly who are at risk for the fracture, they are more likely to receive benzodiazepine. Why? We do not know, but some of the studies, they have found just an association. Now, risk of the fracture and fall has been also been linked to the CYP2C9 allele, and we all know that the Z drugs and the benzodiazepines, they are metabolized by the cytochrome pathway in the liver. So of course this CYP2C9 can influence the blood level of these medications, and that can lead to the falls and the fractures in some of the patients who are consuming sedatives and hypnotics. Now, coming to the safety issues, if we talk about the safety of these sedatives and hypnotics, they are safe in the drug overdose, provided there is no other medication which has been taken with these medications. Regarding the infections and the respiratory infections, data is scarce. In therapeutic doses, none of these medications have been found to worsen the respiratory parameters. Data regarding the pancreatitis, dementia, as well as the premature death is also questionable. If we talk about the Hills criteria for which shows the association between say event and the occurrence of the response, then you will see that though the consistency, strength, temporality, dose response, coherence, experimental evidence, and analogy, there were certain criteria which were meeting for some of these conditions. But when it comes to the specificity of the sedatives and hypnotics with any of these conditions, it was never found. So that clearly shows that there could be some confounders which could also have led to these kind of problems, and and then probably we have implicated the use of the sedatives and hypnotics for all these kind of conditions spuriously. Do we have certain safer alternatives to the Z drugs and the benzodiazepines? Recently, in the past 7 or 8 years, the dual orexin receptor antagonist, as in this selective orexin receptor antagonist, they have been marketed. So far, three DORAs are available in the market: the suvorexant, lemborexant, and daridorexant. The orexin 2 receptor antagonists, they have been found to improve not only the insomnia but also the mood, and the selective orexin 1 receptor antagonist has been found to reduce the motivation to the drug use. So it has been extrapolated that probably the DORAs and the SORAs, they could improve the insomnia without causing the addiction liability. So they have been marketed and discussed superior to the available benzodiazepines and the Z drugs, and they have been say marketed as if they are safer for the long term use. So with this background, can we say that the era of the benzodiazepines and the Z drugs is over? Should we all switch over to the DORAs and the SORAs wherever they are available? A recent study looked at the abuse potential of dual orexin receptor antagonist. It was a randomized active control 6 weeks crossover study. Authors considered the lemborexant in the doses of 10, 20 and 30 milligrams per day, and it was compared with the placebo, zolpidem 30 milligrams per day and suvorexant 40 milligrams per day. 32 healthy, non-dependent people who were using the sedatives for the recreational purpose, they were included. The endpoint of the studies uh, were based on the liking for the drug. So primary endpoint was when the person was given the drug, after 2 to 3 hours, whether they were how much likely did they like the use of the medication for the recreational purpose, and they scored it on a VAS scale or visual analog scale. The secondary outcomes were the VAS score on the overall liking for the drug and chances that they would consume the drug again on the VAS. So the result shows that the lemborexant 10, 20 and 30 milligrams per day, their likelihood at the point, the overall drug liking as well as the chances to consume the same drug again was compared to that of zolpidem 30 milligram and the suvorexant 40 milligram. So the authors, they concluded that the DORAs, though it has been mentioned that or it has been stressed in many of the studies that they have low abuse potential, but if we say that the other sedative and hypnotics, they have the abuse potential, so DORA and SORA, they also have the abuse potential. So does that mean that we cannot use any of the pharmacological agent for the insomnia management? Then what would happen to the plethora of patients who are present in the countries other than the USA, where only 10% of the the trained people who are available who can administer CBTI? And say if we talk about that, which one of the medication is superior and which one should be given? So we need to understand the insomnia in some detail. So if we talk about the insomnia, there are certain phenotypes which are already known. For example, some patients, they have early insomnia, some people they report middle insomnia, some people they have terminal insomnia, and certain people they have mixed type of insomnia. So the medications which are of shorter half life, they are preferred for the early insomnia. Medications which are having intermediate half life, they are preferred for the middle insomnia, and medications with the long half life, they are preferred for the terminal insomnia. Then another type of insomnia is one with the objectively reduced total sleep time. So when we say run the actigraphy or the polysomnography with these patients, you will find that yes, their total sleep time is actually reduced, and it is similar to what they are reporting subjectively. But in certain other patients, though they report of not sleeping well or having the initial, middle, or terminal insomnia, but when you do the ectography or the polysomnography, you will find that there is a gross mismatch between the subjective and the objective total sleep time, and the objective total sleep time is actually much greater than the subjective total sleep time, and these cases are known as paradoxical insomnia or sleep state misperception. These patients might be suffering from certain other sleep disorders which can be ruled out using a thorough history regarding the different kind of sleep disorders, as well as with the help of the polysomnography. So these two phenotypes are already known, and the people who are having the paradoxical insomnia but not suffering from any other sleep disorders, they are likely to have cortical arousal which persists even during the sleep, and that does not allow them to get disengaged from the external as well as the internal environment. So they remain aware of the external environment and the internal environment even when they are sleeping, and they often report poor quality sleep and awareness to the environment when they wake up in the morning. So in such cases, the traditional sedative and hypnotics can be a good molecule to reduce the overall hyperarousal and the activity of the cortical neurons. Another recent paper, it looked for the phenotypes of the insomnia in a sample of 245 patients. So they have discussed about nearly 28 different phenotypes of the insomnia, and all these phenotypes, they may overlap or they can be exclusive to one another. But this is just one study, and probably we need to do the studies in the future to find out the different kinds of phenotypes of insomnia. Now the biggest question is, if we have so many phenotypes of insomnia, is the pathophysiology similar across all different phenotypes of insomnia, or is dissimilar? Again, as of today's understanding, we say that hyperarousal is the final common pathway for the patients who are suffering from insomnia. But to what extent this is actually true, we do not know, and probably we need to delve much deeper in the studies which are dedicated to solve the issues regarding the pathophysiology of the insomnia. So in summary, what we can say that insomnia is a prevalent condition. It has huge health and the economic burden. Whenever you are instituting any therapy, goals of the therapy should be considered. Whatever hypnotics, the benzodiazepines and the Z drugs which are available, they appear safe, similar to the DORAs and the SORAs. Insomnia has multiple phenotypes, but we do not know much about them. So, about the pathophysiological differences, if any, across the phenotypes of insomnia, and till the time we have data regarding all the different phenotypes, that will definitely continue our quest to find out the new methods for the management of insomnia. Thank you very much for your patient listening, and once again I am thankful to the organizers for this opportunity. Thank you.